Could 24 months decide whether your VA urgent care benefit works? No referral doesn't mean no rules.
No, wait, attack the premise. If I'm enrolled, why should one old appointment control a new sore throat?
Because the current VA rule uses two gates together, enrollment and care from VA or an in-network community provider during the past 24 months. Professor Lindquist is here to help us separate that eligibility clock from the referral question.
The clean reading is sequential. First, ask whether the veteran is enrolled. Next, ask whether qualifying care occurred inside that rolling window. Only then ask whether the chosen urgent care location belongs to the VA network.
Picture Marcus on a Saturday. He has a painful ear infection, has used VA primary care this year, and finds a participating clinic. He doesn't pause for a referral because the benefit doesn't require one.
So the headline is true, walk in.
Not yet. The headline is incomplete. Marcus must use an in-network urgent care provider, and the provider must verify his eligibility. The VA page puts that restriction beside the no referral promise.
That visible sentence is the hinge, care within the past 24 months. It isn't the age of the enrollment card and not the date of the last urgent care visit. It is the date of qualifying VA-covered care.
Change Marcus's story. His last VA visit was 30 months ago. Same ear pain, same clinic, same enrollment. The missing fact is recent care. He needs the eligibility answer before assuming VA will pay.
All right, I fold. No referral removes one step.
No, wait. The date matters only if the care counts under the published rule. Check the VA record, or call instead of guessing from the clinic name.
Exactly, Isabella. Both things are true. No referral is convenient, and the other gates still control. Write the last confirmed care date beside the location you plan to use. My fountain pens and card catalog agree. 2 labeled facts beat 2 fuzzy memories before treating a bill as an experiment. Exactly. Before leaving home, verify 3 things: recent qualifying care, an in-network location, and the clinic's ability to confirm eligibility. That 30-second sequence protects the visit from a very expensive misunderstanding.
And keep the categories separate. Eligibility answers whether the benefit is available. Network status answers where it may be used. Medical urgency answers whether urgent care is the right level of care.
Our first ruling is firm. Verify the 24-month care date and the exact network location before a non-emergency visit. You're not eligible under this urgent care benefit when the qualifying care clock isn't met. Coming up, the emergency line nobody should wait to cross. Before we keep going, one small favor that actually moves the needle. If this is landing for you, tap like, then subscribe and turn on the bell so you do not miss the rest. 2 taps, completely free, and it pushes this in front of more people who need it.
The clinic search matters only after the medical decision. A painful ear infection may fit urgent care. Chest pressure, severe trouble breathing, or signs of stroke don't belong in a network scavenger hunt.
But people say everything feels urgent when it's happening. Give me a usable dividing line.
Use consequence, not inconvenience. Urgent care handles minor injuries and illnesses that need prompt attention but are not a serious threat to life or health. If delay could threaten life, limb, breathing, or neurological function, call 911 or go to an emergency department.
That means no one should wait for a benefits answer during an emergency.
Correct. Benefits administration follows safety. This episode is about the urgent care benefit, not permission to downgrade an emergency.
Now take the quieter case. Marcus has ear pain, no severe symptoms, and can't reach primary care until Monday. He uses the VA facility locator or the phone number on the VA page, then calls the clinic to confirm participation.
Let me back up. Directory address first, then call and ask whether that exact location can verify VA urgent care eligibility.
Because directories change, locations within one company may have different contracts, and the person at the desk needs to understand he is using the VA urgent care benefit. One confirmation prevents 2 parties from telling different stories after the visit.
Also remember what urgent care is not. It isn't a replacement for routine primary care, preventive care, or management that can safely wait for your regular team. The no referral feature solves access for a narrow need. It doesn't redesign your whole care plan.
Erica, before we get to the copay table, one more stress test. A broken wrist after a fall may not threaten life, but it may need imaging and stabilization. Is that automatically urgent care?
No automatic label. Severity, deformity, bleeding, sensation, and local capability matter. VA lists X-rays and labs among possible urgent services, but the patient's symptoms and the clinic's capability decide whether urgent care can safely handle the injury. When the safe level is unclear, call a clinical advice line or emergency services.
I concede the premise again. No referral removes paperwork. It doesn't remove judgment.
Wait. That conclusion still needs the safety rule. The safe ending is still severity first, exact participating site second, and benefit verification third. Reverse that order during an emergency, and the checklist becomes dangerous.
Back with us for the front desk handoff, Professor Lindquist. Bring government-issued photo identification and the VA urgent care billing information.
Marcus reaches reception and says one complete sentence. I'm an eligible veteran using the VA urgent care benefit. He doesn't just hand over an insurance card and hope the system guesses.
That sentence identifies the billing pathway. The provider then checks eligibility. The VA instruction tells veterans not to pay a copay at the visit because VA bills any applicable copay later.
Hold on. What if the receptionist demands payment before anyone checks?
No, wait. Pause the transaction. Ask the clinic to verify the VA urgent care benefit using the billing card instructions. Do not turn a disputed front desk request into a blanket promise that VA will reimburse an out-of-network charge.
In the changed version, Marcus says only, I have VA. The receptionist selects a commercial insurance workflow, asks for money, and the confusion grows. Same patient, same clinic, one missing sentence.
This is why the billing card is useful even for someone who knows the rule. It gives the clinic operational instructions and a verification path. Knowledge in the veteran's head can't replace the provider's eligibility check.
So the card isn't proof that every claim will be paid?
Exactly. It roots the claim. Eligibility, network participation, covered service, and any later copay remain separate questions.
Suppose the location verifies eligibility and later mails the full retail bill. Does our neat sequence mean ignore it? Hold on, that can't be the rule.
No. He compares the bill with the visit record, calls the clinic's billing office, and tells VA exactly what arrived. He doesn't throw it away, pay it blindly, or assume a collection notice will correct itself. The saved clinic name, date, and billing card pathway make that follow-up specific.
Keep a simple record after the visit. Clinic name, date, reason for care, and any paperwork provided. If a bill arrives from the clinic instead of VA, that record gives you something precise to question.
Marcus leaves with treatment instructions instead of a mystery receipt. The difference was not charm at the counter. It was naming the benefit, presenting the billing card, and waiting for verification.
Fine. The front desk gets a script, not a guessing game.
Here's what I'd actually do. Name the VA urgent care benefit, present the billing card, and let the provider verify eligibility before treatment. Precision at reception protects the clinical visit that follows.
Now the number people will remember, $30. The dangerous version is pretending everyone pays it the same way.
Correct. For 2026, priority groups 1 through 5 generally have $0 copays for the first 3 urgent care visits in the calendar year, then $30 for each additional visit.
Marcus is priority group 3, and this is visit 4 since January. Let me count it cleanly. Nothing at reception, then VA may bill $30.
Change one fact to priority group 6. Does the same 4th visit still cost $30?
Then the reason for care and the authority connected to the veteran's eligibility matter. Certain special authority-related urgent care follows the first 3 then 30 schedule. Other care in Group 6 can carry a $30 copay for every visit.
And for priority groups 7 and 8, the current table generally lists $30 for every urgent care visit. One headline number hides 3 different billing paths.
Now the counting question. Do repeat visits stop after some limit?
The current VA guidance says there is no limit to the number of urgent care visits. Copays can change with visit count and priority group, but visit 4 isn't a locked door.
FENRIA, the calendar boundary, is easy to miss too. The count restarts with the calendar year, not 12 months after a personal first visit. A December 3rd visit and a January visit can land in different annual counts even though only weeks separate them.
That is the kind of rule that turns a remembered number into the wrong prediction. I would keep the VA bill and visit dates together, then ask VA which visit number and priority group rule produced the charge instead of arguing only that someone online said the first 3 were free.
Wait. The calendar year changes that prediction.
I had that backwards. I was prepared to call it a 3-visit cap, but that claim did not survive the table.
Use the table as an estimate, not a personal determination. Confirm your priority group and the reason VA assigns to the care. Then wait for the VA bill instead of paying a VA copay at the clinic.
Marcus gets an antibiotic prescription. He is relieved, drives across the state line toward home and stops at the first pharmacy. That's the consequence. One ordinary turn changes the payment path. Even my old maps with sea monsters would circle that bridge, because that's where the rule changes.
A valid prescription changes when the car crosses a bridge?
The prescription remains clinically valid, but VA's community pharmacy benefit has an operational rule. Use an in-network pharmacy in the same state as the urgent care visit. The usual urgent supply is up to 14 days.
I mean, what about a 30-day maintenance refill?
That belongs through VA. The community benefit handles an urgent short supply. Routine medicine or more than 14 days should move into the VA pharmacy process rather than stretching one walk-in visit into continuing care.
Now the sharper limit. If the prescription is an opioid, the VA page says up to 7 days or the state limit, whichever is less. Marcus can't assume the general 14-day number applies.
That distinction is worth saying twice. 14 is the general ceiling, 7 or less for opioids.
Yes, also, an out-of-network pharmacy may require full payment. Ask the urgent care provider to send the prescription to a participating location and confirm the pharmacy can process the VA benefit before the clinic closes.
What if the pharmacy can't see the prescription? I mean, that's 3 possible failures. Which one do we diagnose first?
Call the clinic before it closes and confirm the destination, drug, quantity, and transmission. Then ask the pharmacy to identify the exact problem. A missing prescription, an out-of-network location, and a rejected VA transaction require different fixes. Preserve any receipt if immediate clinical need forces payment, but don't promise reimbursement.
Marcus turns around before crossing the state line, fills 7 days of the medicine actually ordered, and contacts his VA team about anything ongoing. The story ends with treatment continuity instead of a surprise cash receipt.
One more boundary. Can his spouse use the same urgent care benefit?
No, VA states that family members can't use the veteran's urgent care benefit. Keep family coverage, travel reimbursement, and the veteran's clinical benefit in separate lanes. Eligible travel reimbursement for an unscheduled visit may also be one-way only.
3 quiet limits carry real stakes: the same state, the short supply, and the actual beneficiary. None appears in the words "no referral," which is why the whole pathway matters.
Back with us for the final decision path, Professor Lindquist. We can now compress the benefit into one safe order.
I want the edge case. Make the symptoms worse and the eligibility facts weaker.
Here's the ruling. If symptoms could threaten life or health, then the urgent care benefit stops being the first decision. Use emergency care. An ambulance doesn't wait for a network search.
Before we crown that, would the same logic survive a weaker eligibility record?
Now change the case. Chest pressure. Last confirmed VA care 30 months ago, but an in-network urgent care center nearby. Does the 24-month miss block him?
No. If the symptom is an emergency, then safety controls. The stale eligibility fact blocks only the non-emergency urgent care lane. He calls 911 or goes to an emergency department.
That is the governing hierarchy. Medical safety comes first, benefit eligibility second, and network and billing mechanics third. Moving a lower question above a higher one creates either health risk or payment risk.
Now restore the original ear infection and recent VA visit. Same person, different condition. Does the ordinary urgent care path reopen?
Urgent care becomes reasonable. The 24-month gate is supported, and Marcus can confirm the exact clinic. He brings identification and the billing card, names the benefit, and lets the provider verify eligibility before treatment.
Then he checks the prescription lane before driving away. Participating pharmacy, same state, short urgent supply. He keeps the visit paperwork and watches for any VA copay bill later.
I had it backwards. The premise is wrong if no referral becomes no gates. One gate disappears, the others still have an order.
Well put. The benefit is genuinely convenient when it's used as written. Verify the clock and the location before a non-emergency visit, and never let either verification delay emergency care.
Professor Lindquist, thank you for keeping eligibility, network, and medical judgment in their proper order.
Fenrir, the whole episode changed when you stopped treating no referral as the first question. Marcus did not need a permission slip, but he still needed the right level of care, a current eligibility fact, the exact participating location, and a clean handoff at reception.
The premise is wrong if no referral gets translated as no gates. Emergency symptoms bypass this pathway. A non-emergency problem moves through eligibility and network checks. The billing card routes the claim. The pharmacy has its own limits. That is a system, not a slogan.
Glad to help. One orderly check can prevent a very disorderly bill.
If this gave you a safer urgent care plan, like the video and subscribe. Share it with a veteran who keeps hearing no referral without the 24-month rule. Which of the 3 checks would you make before leaving home? The one rule to carry out of here is the order: safety, eligibility, exact location, then billing. This is Professor Erica. Thanks for watching and signing off.